And this is a little bit more stubborn to deal with. So we will show you guys in a bit how to approach each one of these. So just to get everyone on the same page here, I've provided a couple of diagrams of the ear here. So we have the outer ear here. We have the ear canal. We have the middle ear. So I have the eardrum, the malleus, the incus, stapes, and then we'll get to the inner ear. So here you have the cochlea, and here you have the vestibular system. So the cochlea is dedicated for hearing. This guy right here, and it converts sound pressure patterns from the outer ear to electrical chemical impulses, and this is passed on to the brain through the auditory nerve. Okay, the vestibular system, this structure right here, monitors motion and position of the head in space by detecting linear and angular acceleration. And so this component, this vestibular system, is divided into two areas, or two sections: the semicircular canals, these hula hoops I was talking about, and the vestibule, which I'll talk about in a moment. So just to kind of expand that vestibular system, so you got the otolith organs, which are these two organs, the saccule and the utricle, and you have the semicircular canals. You have the posterior semicircular canal, the horizontal one, and the anterior one. Now, going first with the otolith organs, those two organs over here, they're called the saccule and the utricle. They sense linear acceleration through these hair cells, and they're innervated by the vestibular nerve, okay? So the saccule, right here, basically focuses on vertical movements, and the utricle focuses on horizontal movements. So this one right here focuses on horizontal, vertical. So as you can see here, these two organs here actually are where that crystal, the crystals that seep into the semicircular canals, that's where they're originally housed in. So you can see them right here. So let me give you guys an idea of exactly their purpose right here. So if you're, let's say, if you're driving, and automatically there's something in front of you, and you press on the brakes immediately, so your body will shift forward. Your body will shift forward, but also, as you can see here, this is the utricle.
May I have your attention, please? Code White, Central to Emergency Department, subacute 19. Code White, Central to Emergency Department, subacute 19.
You'll see here, there are these tiny crystals, and these are those crystals I was talking about, and they're kind of overlying those hair cells. So with you moving forward, those crystals will move forward, and they'll give your body the impression that you're moving forward. Same thing with the saccule. So the saccule has itself these crystals. So let's say you're going up and down the elevator, or even more exciting, up and down drop zone, right? So you can imagine drop zone. When that thing is coming down, you're going to feel like you're going upwards. So same combination here. So when the elevator is going upwards, the crystals will go in the opposite direction, giving you the impression that you're going the other direction. So that's how those otolith organs work. The semicircular canals, the anterior, the posterior, and the horizontal ones, are perpendicular to each other, so 90 degrees of each other. And these three contain endolymph fluid, which is kind of a clear fluid, and hair sensors. And these bend to detect rotational movements of the head, so any kind of turning motion. And these cause an excitatory and an inhibitory reaction that sends messages to the head's angular acceleration. Just to make a distinction between these two, in order for these two to detect something, your head has to stay still. Whereas when these are in action, when these are moving, it's when your head is moving, or when your head is in an angular position. Okay, just to make that clear. And typically, as you can see here, when you're moving forward and back, you're activating the posterior semicircular canal into flexion extension, or when you're nodding, yes. When you're nodding, no. When you're going into rotation, you're activating the horizontal canal. And when you're going from side to side, when you're tilting your head side to side, you're activating the anterior canal. So that's how your body interprets, that's how your vestibular system plays into your balance and everything else as well. Now, in order to determine whether a patient is appropriate for vestibular physiotherapy,
may I have your attention, please? Cancel Code White Central 2.
we first perform a very thorough assessment. So in order to determine what the problem is, we first have to figure out what it is. So we would first provide an outcome measure to a patient, simply to get an idea of what's happening. These are the more common outcome measures that you typically see if you're treating vestibular disorders. And these are simply to determine, the patient's current functional limitations. The dizziness handicap inventory is actually what we use at our clinic. And I've actually kind of expanded it here for you guys because I wanted to show it to you guys. I don't know if you guys in the back there can kind of see it clearly, but I'll kind of walk you through it. The dizziness handicap inventory was developed to measure the self-perceived level of handicap associated with the symptoms of dizziness, okay? And it's a 25-item questionnaire that can be used for patients with peripheral and central vestibular pathology. And essentially, the higher the score, the more the patient circles, the higher that indicates a greater level of handicap or a greater level of dizziness. Now, from this questionnaire, there's also been created a 5-point subscale that's been identified, and in particular, you're looking at 5 areas: looking up, difficulty getting out of bed, quick head movements, rolling over in bed, and bending forward. So these 5 could be considered the BPPV subscale, and they're especially important in helping clinicians deciding whether or not to perform a diagnostic maneuver called the Dix-Hallpike. So these 5, simply by asking your patients these 5 questions, you can get a good idea of what's happening and whether further testing should be indicated. And as you can see in this table by Whitney and all, this figure shows that dizziness patients, their chance of having BPPV increases up to 35% as more of those 5 items are mentioned by the patient. So the 5-point BPPV scale is important because it is not uncommon in acute care settings, such hospitals, for people to have MRI examinations in the attempt to determine what the cause of the vertigo is. But by using this 5-item DHI BPPV subscale, you can assist in the diagnostic screening process that could help control healthcare costs, and the patient could then be seen by a skilled otolaryngologist or a physiotherapist that's trained in the treatment of BPPV. So once the outcome measures have been completed and you've performed a thorough subjective assessment, that's when you would want to get into more of an objective examination. You would want to be testing certain things, including the ocular motor testing, vestibular ocular reflex testing, and also your gait and balance. So essentially what you're doing with these tests is you're trying to figure out whether they have any underlying issues, if there's any central nervous system conditions, if there's any nystagmus when their eyes are fixated on a certain object, when their head's not moving, when you're noticing nystagmus, twitching of the eyes in one direction or another. This could give you certain hints that you would want to either, if it's something like a central nervous system disorder, you would obviously want to refer them back to your doctor or the referral source that brought them to you, or essentially kind of delve into a little bit more cautiously, essentially. But once all these have been cleared, you can actually go ahead with what's called the Dix-Hallpike maneuver. And this is a fairly common maneuver, and it's actually considered the gold standard test for diagnostic testing for the posterior semicircular canal. So the diagnostic criteria for the posterior semicircular canal BPPV includes vertigo that's associated with nystagmus, that is torsional, so that's kind of twisting, that's in a twisting fashion, towards the dependent ear. So this gives you an indication of whether it's the left or the right, and in the direction of upwards when the patient is put into that provocative position. And vertigo and nystagmus usually are brought on, and it doesn't really last, the vertigo and nystagmus doesn't really last any longer than 60 seconds, essentially. So just to give you guys an idea of what of what it is, this is a great diagram here, but I'm also going to show you guys an actual
Your attention, please.
live shot.
Noseworthy, please call extension 2216. Irene Noseworthy, please call extension 2216.
So Kayla, I'm going to get Kayla as my volunteer here. Kayla is going to have a seat on the bed. And essentially, in order to, let's say I'm suspecting the left inner ear is the issue. what I would ask, so I would obviously want to make sure I do both sides, but I'm going to do the more effective side first. So I'm going to ask the patient to go into long sitting. So you're going to raise your legs. And you want to make sure that you have the appropriate tools to be able to screen this. So before you get the patient into this position, through your objective assessment, you would have wanted to screen for any, you would have wanted to screen for full range of motion, obviously. You wouldn't have wanted for any medical conditions, which I'll be talking about in the future, in the upcoming slides. And you essentially want to clear the neck. So you want to make sure they have full range of motion and that all other conditions are clear, so that you can go ahead with the maneuver essentially. So if I'm expecting something's going on in the left inner ear, I would be on that side. And I'm going to ask the patient to grab my arm, actually, so that you have good security, so that they feel secure when they're in that vertigo stage, when that vertigo feeling is coming on. And I'm actually going to get their head positioned into 45 degrees. I'm going to ask the patient to maintain eye contact with my nose. And what I'm going to do, I'm going to obviously explain to them what's going to happen. Kale, I'm going to actually tip you off the edge of the bed. I'm going to extend your head past the bed so that your head is into 90 degrees. And at that point, you may experience some vertigo, okay? You may also get some nystagmus, which is the twitching of the eyes. And we're going to hold you in that position to figure out if you actually have what's called BPPV. Okay, you ready to go? So we're going to go on the count of 3. Ready? 1, 2, 3, and down. So you would obviously want the patient into extension. You want it to be 45 degrees in that plane, because you're testing the posterior canal of the left inner ear here. And what will happen is the patient obviously would have the provocative symptoms. So the vertigo, they're going to feel, they're going to be grabbing your arm because they're going to feel like the room is spinning. So you want to just secure them, make sure that they're secure, but as well you also want to be making sure that you're using yourself good biomechanics, right? So you want to make sure you get down low. If you have a high-low bed, you can use that to elevate the bed so you're not straining your back. So from this position, I would typically go into the Epley maneuver, which is a type of maneuver to treat BPPV. But simply for the purposes of the assessment, at this point, once the patient presents with the symptoms, okay, I'm going to sit you up now, okay? And what will happen is the reversal of that vertigo will come. So they'll start to feel the vertigo coming on again. And essentially what you see there actually is the tiny crystals that are going through that canal there. So if you could hold on for a moment, I'm just going to continue on. Yeah, so basically you're looking at 3 things actually when you're doing the Dix-Hallpike. You're looking for latency. So you're seeing how long it takes for the patient's vertigo to be brought on in nystagmus. And that'll give you an indication of whether it's cupulolithiasis or canalolithiasis. Usually if it's sudden, if it's almost like right away, what you'll notice is it's canalolithiasis. So if it's cupulolithiasis, it'll be a little delayed. And essentially you also want to look at the direction of the eyes. So what you'll typically see here, as you see in this patient right here, the eyes will be looking upwards and to the left. So going upwards would give the patient, give the clinician the indication that's the posterior canal. And going to the left, the eyes will be twitching to the left, which would give you the indication that it's your, in this case, the right inner ear. That's the problem. And also you want to be looking for duration. So latency, direction, and duration. Duration essentially gives you an indication of how many crystals are in there essentially. And so obviously the speed of the maneuver and the positioning of your head is important. So as you can see there, I hadn't lined up Kale exactly so his head was tipping off the bed. So I would want to make sure that I line his pelvis up properly so that his head is simply tipping off so you get into that 20-degree angle. So as you can see here, so we have the 3 different types of BPPV. I'm going to show you guys a clip of each one now, actually, that kind of demonstrates that fairly clearly. So this one here is the posterior semicircular canal. What you'll notice is, so the patient here, they're wearing goggles. The clinician is actually tipping the patient over. And this is the latency period. You won't see anything. And at one point, you'll start to notice there's a little bit of twitching of the eye. The eye will be fast motion, fast phase upwards, and it'll be left. So this is the left eye. And the nystagmus is going upwards and to the left. So you give you the indication that's the left inner ear that's the issue, posterior semicircular canal. Now, just to distinguish that with horizontal